hand it over to you all to take over.
Good morning, everybody. Can you hear me okay? I'm a little vertically challenged with the mic. Okay, great. Thanks for joining us. My name is Stephanie O'Leary. I'm a physical therapist with Children's Hospital of Philadelphia. I work in our mitochondrial clinic there, and I've also been a part of the UMDF Research Pavilion for the last 3 years. So if you visit us there at all during today's conference or in past years, you might be familiar with some of the assessments that I'll talk about today. Okay. I have no conflicts of interest to disclose today. So today I'm really happy to talk to you about physical therapy and our role in mitochondrial disease. We're going to talk about the most common physical therapy impairments that we see in patients with mitochondrial disease and how we assess for those impairments. And just kind of give some broad overview and tips for things that you can consider at home. But you should always check with your medical provider before starting any new exercise program. And due to how heterogeneous the mitochondrial patient population is, it's always best to work with your local physical therapist for any individualized treatment recommendations. Okay, so what is physical therapy? What do physical therapists do? We are movement specialists. We are a part of the medical team that specializes in functional mobility. We're trained to help enhance and adapt your movements to best meet your needs. Your physical therapist will create an individualized treatment plan based on specific goals that are meaningful to you. There's been a lot of research done and found some nice benefits of exercise with patients with mitochondrial disease. Some of these benefits include improving functional capacity, increasing muscle mass, increasing maximal oxygen uptake, increasing work capacity, and increasing walking distance. So given all of these evidence-based benefits, your physical therapist could be an important part of your medical team. Okay, so first I'm just going to go over some general exercise recommendations for patients with mitochondrial disease. Before you start, you always want to obtain medical clearance from your provider. This would include your primary mitochondrial physician, maybe your primary care, and if you're followed by cardiology, you should also get clearance from them as well. My overall theme in my part of our talk today is that you should begin slowly, progress gradually with your exercise. Progress your duration and intensity of exercise gradually over time. You should alternate between endurance-based activities and strength-based activities to kind of give your muscles adequate rest and incorporate rest days as well. You should be consistent with your routine to avoid detraining effects. Find activities that you enjoy, something that's going to keep you motivated and keep you consistent week to week. It's very important to stay hydrated before, during, and after exercise. And I would add to that also having adequate nutrition on board as well. When you should not exercise. You should not exercise if you are feeling ill or have a fever, if you have been fasting for more than 12 hours, or if you're experiencing muscle cramping, muscle pain out of the ordinary. Okay, so this slide lists the most common physical therapy impairments that we see and hear about in patients with mitochondrial disease. The first being decreased muscle strength. This could be having trouble lifting something to a shelf, having trouble getting up from the floor, or noticing that your child prefers to sit and play instead of squatting to pick up toys. Next is muscle fatigue, can be a huge factor. This could be your legs feeling like they're burning after going up a few steps, your arms getting very fatigued after bringing in a bag of groceries. Intolerance to exercise. This would be feeling like you need to stop and rest when you're on a walk with your family, or not being able to participate in a scheduled activity because you were very active the day before. Difficulties with your balance. This could include tripping, or feeling unsteady in an unlit hallway. And lastly, trouble with dexterity. This could be trying to manipulate coins in your hand, fasten buttons, things like that. We screen for these impairments in our clinic through a few different assessments. But if we find that a patient's having some significant difficulties here, we usually refer out to our occupational therapy colleagues who have a little bit more specialization in using your hands as efficiently as possible. Okay, so we assess for strength in a few different ways. In our clinic, we use a handheld myometer to get an objective measure of how many pounds your muscles can push or pull. We test specific muscles and specific muscle groups on both sides of your body, so we can get a sense if there's any asymmetries. We also test strength in more functional capacities, so looking at things like squatting, getting up from a chair, getting up from the floor, lifting a gallon jug, things like that that are a little bit more applicable to day-to-day life, more than the myometer. Okay, so thinking about starting some strengthening exercises, there's been some evidence in the literature showing benefits for a consistent resistance training program for patients with mitochondrial disease. One study found that after 12 weeks of an overload training program, that patients showed increased muscle strength and improved muscle oxidative capacity. The main important thing to keep in mind if you're going to start some strengthening exercises is that you want to maintain good form and have proper alignment. So you want to be always engaging your core, don't lock out your knees, do not hold your breath, maintain a consistent breath through your movements, things like that. And if you notice that your form is starting to break down, that is a sign of fatigue and that you should stop and rest. It's always more important to prioritize the quality of your movements over the number of repetitions. Using weights are not always necessary to appreciate some strength gains. Body weight resistance is perfectly fine and often a great place to start. But again, you should begin slowly, progress gradually, and really this should be guided by your physical therapist. Moving on to muscle fatigue and exercise intolerance. These two things can sound pretty similar. They do have some subtle differences, and we assess for them in slightly different ways. So muscle fatigue is difficulty sustaining strength over a period of time. In our clinic, we assess this using repeated myometry, where we test the same muscle or muscle group using the myometer with consecutive repetitions. And then we're looking at your strength output from the first rep to the final rep to see how large that difference is. For exercise intolerance, this would be becoming too fatigued to continue with an activity or having excessive fatigue or muscle soreness that's out of proportion with the intensity of the activity. We assess for exercise intolerance using some functional time testing, including a 30 and 60-second sit to stand, as well as a 6-minute walk test. Even though there are some subtle differences between these two types of PT impairments, you can train and improve them using endurance exercises. Okay, so there's also been some research demonstrating the efficacy and importance of endurance training for patients with mitochondrial disease. One study found that after 14 weeks of training, patients demonstrated improved tolerance for submaximal exercise, improved work capacity, and more efficient oxygen utilization in skeletal muscle cells. However, they also showed that these benefits and improvements did not remain once the exercise program was stopped. They returned to baseline. So it's really important with all of your exercise, particularly with endurance exercise, to maintain a consistent program to avoid detraining effects. There is really no right or wrong when it comes to type of endurance exercise. Do what feels right for your body and what you enjoy doing. Swimming, walking in a pool, walking indoors or outdoors, cycling, even an under-desk seated cycle are all great options, and this is by no means an exhaustive list. There's also no magic number of kind of how many minutes that you should start with or aim for, because everybody is starting at a different place and everybody has different goals and needs. What I tell my patients in clinic is that whatever mode of exercise you choose to do, however long you feel like you're able to do it, start there, and then assess how you feel 24 to 48 hours following that activity. If you feel excessively fatigued, excessively sore, then perhaps that either intensity or duration of the activity was a little bit too much for you. So you can either try walking slower or decreasing the amount of time you are doing the activity, and then assess from there to find like that sweet spot, and again, progress gradually, guided by your physical therapist. Okay, and then lastly, balance and coordination. We assess these things using both static and dynamic postures, including standing with feet together, standing with feet on a line, which is, or feet in front of each other, called tandem stance, and standing on one foot. We also look at some dynamic postures, including tandem walking or walking on a line, and walking with a more narrow base of support. For the static postures, we assess both with your eyes opened and your eyes closed to decipher how reliant you are on your vision for your balance. So you can train your balance just like you would train a muscle through repeated practice and consistency. You can utilize the same positions that we test for to practice your balance. And you don't need to spend a significant amount of time on this. I recommend trying your best effort for 2 or 3 repetitions and moving on to your next posture. It is always important to have a countertop or a sturdy chair, or even better, a family member or caregiver nearby so that you have something to reach to and steady yourself whenever you're challenging your balance to maintain safety. Some general kind of tips that you can consider if you find your balance to be a challenge would be keeping your walkways clear in your home to avoid tripping, especially if you find that balance with your eyes closed is a challenge. Considering adding some night lights to a hallway, especially maybe at nighttime when you're using the restroom, or just being extra mindful on times when your vision could be occluded. Like if you're standing in the shower and you're going to close your eyes to rinse your hair. Some special considerations for our kiddos. So for children, we don't typically, direct them in their movements. We use play. Children learn through play. Play is exercise for them. So we want to make our time and our activities as fun and engaging and as play-based as possible. And we utilize toy selection and kind of manipulating the environment to produce the activities that we would want to see, that we want to work on. So for example, if a child is working on pulling to stand, maybe the couch is a little bit too high for them, that they would really have to reach and they can't quite get the right leverage. If you take the couch cushion off, now that height is a little decreased, that might be more at their chest level, and now they may be able to do more repetitions than they would otherwise. Similarly, if you're perhaps working on squatting, maybe they don't have the control to get all the way down to the floor, but if you bring the floor up to them by maybe using an upside down box or flip over a laundry basket, place some toys on there, now they can do that squatting motion in a smaller range of motion and build on that control to slowly progress down to the full motion. Kind of choosing toys can also be helpful, and it doesn't mean that you need anything new or fancy. If I want a child to hold a position, if we're working on kneeling or if we're working on standing, I'm going to choose something that's going to hold their attention for a little bit longer. Maybe building blocks, singing songs, coloring, things like that. If I want to work on something more dynamic, if we're taking a few steps, if we're working on squatting, I'm going to get something that's easy to have two piles of toys that we're putting them one place and playing with them in another. So either using puzzles or maybe like farm animals in a barn, something that's easy to encourage them to move from one place back and forth. So these are just the references for the research that I spoke to. And then my next slide is just for questions, but I think we're gonna hold on questions if you don't mind. And I'm gonna pass the mic over to my colleague Anna, who's gonna go through some occupational therapy considerations, and then we'll take questions at the end. Thank you so much.
Okie dokie. Good morning. You all awake? Can everybody hear me all right? Okay, wonderful. My name is Anna Haertling Clearman. I work at UT Health Houston with our mitochondrial team in our Center for the Treatment of Pediatric Neurodegenerative Disease. So I get to consult in our mitochondrial clinics with our physicians as well as participate in the clinical trials space. So that's me. I'm going to talk to you a little bit about occupational therapy today. Before I get started, do we have any clinicians in here today? Clinicians, wonderful. What about people with mitochondrial disease? Awesome. And then people who love someone with mitochondrial disease? Wonderful. Just wanted to kind of see the makeup of our presentation here. I know it's on the family track, but we kind of bounce around, so I wanted to know who we've got. All right. So I have no relevant financial or non-financial relationships to disclose related to this talk. So today, our objectives are to define occupational therapy. Most of you, I imagine, if you're in this room, have probably encountered OT before, have heard of OT. Sometimes it is such a broad field that I wanted to do a good review of what all we do, because a lot of times I think people don't quite understand the full breadth of our profession. So I want to do a good deep dive into that, because just like the Mito community, there's a wide range of ages and abilities and things like that. And the same thing with OT. We can address sort of all of that, and I want to go into some details about that. I also want to just talk about the role of OT in the multidisciplinary team. So we've already heard from the physical therapist. We unfortunately don't have a speech therapist with us today, but that's another profession that we work very closely with, as well as with the physicians, social work, et cetera. So just kind of talking about the specific things that OT can address. I want to describe and define occupations. That's actually, there's a reason we are called occupational therapy, and it's kind of fun fact definitions and things like that that people might not be aware of. So I want to talk specifically what an occupation is, and then talk a little bit about strategies to identify the right therapist for you or your loved one, as well as some insurance considerations when it comes to attaining and maintaining therapy services. So, one of my biggest pet peeves is when people say, oh, well, OT's for arms and PT's for legs. Or, well, OT just does fine motor and PT does gross motor. These are true statements in that those are things that we do address and we can do, but it's not quite as simple as that, and there's a lot more, I think, overlap. So I have one of the doctors I work with, not a Mito doc, but he likes to bug me by telling the residents that OT does the arms. And I'm like, stop it. No, he knows it's not true, but it's one of my pet peeves is having that generalization, because there is just so much more to it, as you've already heard from the physical therapy presentation, and I hope to show you with the rest of this. So what is occupational therapy? According to the Occupational Therapy Practice Framework, the definition of OT is the therapeutic use of everyday life occupations with persons, groups, or populations for the purpose of enhancing or enabling participation. So the big part of that is we utilize occupations to enable participation, or in another way to say it, independence, facilitating as much independence as possible in our day-to-day tasks. So occupations are specifically defined as the everyday activities that people do as individuals, in families, and with communities to occupy time and bring meaning and purpose to life. So when people come to me and say, oh, I don't need OT, I already have a job. Occupation is more than just your profession. It's really the occupation of living. And I hate that I can't see the, let me pull up my notes here because the transcription is covering the bottom of this slide, and these should be uploaded. If not now, they will be. One moment. Oh, did you do that? Thank you, Anthony. So occupations include things that people either need to do, want to do, or are expected to do. So the example I like to give with this is, you might not want to do your laundry, but your parent might expect you to do your laundry as a part of your day-to-day. Occupations can be anything that you need, want, or are expected to do, but because of your diagnosis, because of the physical, cognitive, et cetera, manifestations of your diagnosis, might be difficult. You might not be able to do the way that you like, and those are the things that OTs can address. So we treat patients across the lifespan. So I see we've got some little ones here in the room. Just like people with mitochondrial disease are of all ages and abilities, OT can address patients across the lifespan. So with little ones, like where it's already addressed a little bit today, we might be doing very play-based interventions to attain milestones. Just being able to move around well enough to play. If play is the occupation, we're working on that with children. School-age children, we might be working on things related to school. Driving, getting a job is in our wheelhouse in helping you with the skills that are needed for that. It's just not all we do. And then all the way to elderly ages and anything that might be affected at that time. One thing I really love about occupational therapy is that we really consider everything about the person. So this is just one model framework that we learn about in school, but it's the one that really stuck with me throughout my career. It's the person, environment, and occupation, or PEO model. So we're not just looking at the person and looking at, well, you have a hard time putting your socks on. Well, what if the reason you have a hard time putting your socks on is that your bedroom is set up in such a way that it's making it difficult for you to get your socks? We have to think about the environment. You have to think about, who's there to help? Do we set goals for something that patients don't necessarily need help for? We have to consider their environment, what their caregivers are willing to help with, what is meaningful to them. But we're just a really holistic profession in that we don't just consider the person, we don't just consider the occupation or the task that they need help with. We're looking at the whole picture and how it all affects each other. So different areas that OT can address are activities of daily living, so dressing, grooming, bathing, etc. Basic tasks, daily tasks. Instrumental activities of daily living are some of those higher level daily tasks. Health management, rest and sleep. Sleep is an occupation, and quality of sleep can be something that we talk about and help with. Education, work, play, leisure, and social participation. So I put all this up here just to show the breadth and depth of what OT can address, because your individual experience with OT may have only addressed one of these areas, because that was maybe the most important thing at the time. But I wanted to bring some knowledge to the group about what all else can be addressed and what you might refer to OT for, or what you might be able to ask your therapist to include in the plan of care. So going back to my slide of PT is gross motor, OT is fine motor, the way that I like to describe it is PT focuses on mobility and OT focuses on function. However, there's still some overlap and we work extremely closely together. So this is my little OT PT BFF slide to show that we are all part of a team. And as Stephanie mentioned, there may be areas that one therapist may be a little more specialized in than another, and we would defer to each other for those things. But yeah. So when I was putting together this presentation and trying to consider how OT specifically works with patients with mitochondrial disease, I actually had a really hard time because I quickly realized that the things that OT addresses with any population are the same things that we may address with people with mitochondrial disease. I think it's in a slide later that I say, we're not necessarily treating your diagnosis, we're treating the things that are meaningful to you and that you might be having trouble with. So a lot of these things are not going to really sound very specific to mitochondrial disease because it's just life. These are things, daily tasks that anybody may have difficulty with. So I already defined ADLs a little bit, but that's everything from dressing, eating, bathing, grooming, toilet training. For the little ones, the IADLs can be home management, so being able to clean. That goes into, the energy it takes to maybe vacuum, talking about planning out your day to do those big daily tasks. If you have fatigue and energy issues, meal preparation, shopping, driving, taking care of your pets. That can be something that can be very meaningful for you that you might want to be more independent with, and we can address that. Health management goes into being able to manage your medications, being able to manage your exercise program, fitting that into your life. And then rest and sleep. The big one I put there is the energy conservation. So OTs specialize and learn a lot about strategies to help you conserve your energy, plan your day. That is probably the biggest conversation that I have with a lot of our patients is management of that fatigue. And how you can still live your life. You just might have to plan ahead a little bit more. Education, so goes back to the kiddos. We may work on some of those more fine motor skills. We're not only fine motor, but we do address fine motor. So it might be motor skills for handwriting, sensory processing, being able to manage all the sensory input that you're getting in a crowded classroom and helping kiddos strategize how to function in that setting. They work with job performance or volunteering and helping figure out the best ways for you to engage in those things with the physical and cognitive abilities that you have. Play and leisure, I feel, are pretty self-explanatory. It's just any of those things that you enjoy doing, and that can vary from person to person. And then social participation would be participating in the community, socializing with your family, and being able to make that work within your day. Okay, so finding an OT. How many of y'all in here receive OT services or have in the past? Wonderful. So one of the biggest questions we get when I'm helping, because part of my job role is to help refer and facilitate referrals from our physicians to the community therapists. And one of the biggest questions I get is, well, I want a therapist that specializes in Mito. And I know the title of these presentations is Ask the Mito Therapy Specialist, which is kind of a made-up thing. There's not really technically a Mito therapy specialist. There's not like a special certification we get to be able to work with patients with mitochondrial disease. OT, PT, speech therapy, there are some specialty certifications, but for the most part, we learn to work with patients of all walks of life, of all abilities. Anybody that's a mitotherapy specialist is probably just someone who has worked, in a setting like we do with specifically patients with mitochondrial disease, but unfortunately, that's not going to be the norm out in the community, even out, in more rural areas, things of that nature. So my advice is to not get too hung up on that. It's a great opportunity actually for you to advocate for the mito community and to educate your therapist about your diagnosis or your child's diagnosis. If they're a good therapist, they're going to want to learn and want to understand. And I just want to reiterate that we don't treat a diagnosis. I'm not working to cure your diagnosis. I'm looking at the symptoms and impairments and addressing those as they relate to your ability to engage in your daily tasks. And I just put that there's definitely a huge importance of collaboration between your mitotherapy team and your community therapists. So one of the things that I do is consult with the community therapists in order to help them learn more about it. I've had patients who've come in and said, "Oh, my therapist is just pushing the kiddo too hard. They're really exhausted." As Stephanie was talking, are we okay to? Okay. No, the therapist just seems to push them too hard. For the next 2 days, they're completely wiped out. They can't do anything at all. That's an opportunity for your medical team, whether it be if there's a therapist on the medical team or someone else who can talk to those community therapists as a learning opportunity. And then one thing that I have found that's really helpful is you can have a therapy company with a wonderful reputation, but the therapist that you get partnered with may or may not be the best fit for you, because we work with people. So I might work better with one person than another, and I might have a colleague who connects more with a patient than I might for whatever reason. And so trying not to get too hung up on either the reputation of the company or finding that specific therapist, but just finding a good fit and someone who's going to listen and make sure to address the things that are meaningful to you. So one of the things that I have to deal with in my job a lot is related to insurance. So I'm in Texas. Texas Medicaid is very notorious for focusing on progress and saying, "Oh, well, there's a lack of progress or there's a plateau, so you don't need twice a week therapy anymore. You only need once a week therapy." And I've written many appeals and have sat in on fair hearings. And one of the main things that I like to address is that, if we're doing a standardized test and the patient has the exact same score on that test today as they did 6 months ago, that doesn't mean that they didn't progress. They didn't regress. And for a lot of these mito diagnoses, we expect sometimes without intervention, we would expect things to go backwards. So if we're staying in the same spot, we really are making progress. And so helping make that point, not only to the insurance companies, but to the therapist, because there's also some therapists that I know that follow the rules, and they're like, well, they're not progressing, so I feel like I can only recommend once a week therapy, or whatever the case may be. So, just looking at it through that lens is helpful and can help with appeals. And then, so frequency and duration recommendations, that goes back to, like I said, insurance may recommend something that's different than what the therapist or the physician said, and just working on making sure we're all on the same page there. So that is my primary reference for the definitions of OT and occupations, and we'll take some questions. So for either physical or OT related topics. Yes.